So I will start with the data that was presented as poster in this ESMO 2020 Congress. There were several studies that were actually presented as posters. More than 50 posters were presented, and they showed mostly studies that were based in real-world data. Despite the fact that we have the best clinical evidence coming from clinical trials, being able to confirm the data in a real-world data set remains important, in my opinion. So I'm just going to mention a couple of topics that were addressed in posters. One that refers to therapy in older patients. So although no information was provided regarding the comorbidities, there was data from a significant number of patients that showed that systemic therapy, namely targeted and immunotherapy in this setting, it seems to be safe and also achieve the same outcomes as patients that are younger. So the message is older patients should not be included or should not be excluded from receiving targeted or immunotherapy only due to age, because they seem to derive the same benefit. Then there were studies or posters that addressed sequential therapy. The caveat of this analysis is the fact that only patients that actually received at least 2 therapy lines were included in this analysis. Patients that have a very good prognosis on the first line of therapy, or those that have progressed very fast under the first line of therapy, were not included in this analysis. However, the data that was shown here, and in the absence of clinical trials that address this question, or for which we have data from clinical trials, I think the data that we see here can be used to make some therapeutic decisions. So one of the works that was presented addressed the therapy sequencing of immunotherapy followed by target therapy, or target therapy followed by immunotherapy in BRAF mutated melanoma. And they analyzed data from 300 patients, and they showed that patients progressed relatively fast, regardless of the first or second line therapy, with a similar risk of progression and mortality. Also, another work that showed that a second-line therapy, patients that need a second-line therapy seem to do worse in terms of progression-free survival and overall survival. And finally, another work with an Asian cohort that evaluated the efficacy of salvage therapy after failure of anti-PD-1 monotherapy, that showed that actually the salvage therapy with ipi/nivo might have more limited clinical efficacy in this Asian population after progression under PD-1 therapy, although they need a longer follow-up. And also they showed that the patients that progressed under PD-1 therapy and that received BRAF/MEK still appear to have a good outcome compared to other salvage therapies in patients that have BRAF mutated melanoma. The third aspect is the systemic therapy in another melanoma subtypes. 2 posters that evaluated therapy in uveal melanoma. The first one that showed that in uveal melanoma, using the genomic profiling for treatment selection led to a 65% of patients that received target therapy based in this genomic profiling, although the outcomes were rather unsatisfactory. And for other work that showed that the predictors of best response to immunotherapy in this subsetting are the low LDH at the time of diagnosis, and also the time from the first diagnosis to stage 4 that needs to be more than 2 years. So these patients would have better outcomes to immunotherapy. Also, for patients with NRAS mutated melanoma, work from Italy showed that the patients that are treated with immune checkpoint inhibitors as first line have equally benefits regardless of their NRAS mutation status. And finally, data that came from real-world analysis that evaluated systemic therapy in patients with melanoma brain metastasis. So combined immunotherapy, target therapy, and comparison between the population of patients included in clinical trials and treated in a real-world setting. The number of patients included in these 3 reports is quite high, and I think they deserve a second look in order to see the outcomes of these patients with melanoma brain metastasis treated in real-world settings. There are more data presented as posters, but these are my picks for these highlights. Then moving into the mini oral presentations, there were two trials that evaluated vaccination in melanoma patients, one in the adjuvant setting and another one in patients with advanced melanoma. The first one evaluated the therapy of dendritic cells versus placebo in patients with stage 3B and stage 3C melanoma. The trial didn't achieve its primary endpoint because there was no difference in terms of relapse-free survival for patients treated with placebo or dendritic cells. And the trial was also stopped earlier due to the approval and reimbursement of pembrolizumab in this setting. However, there seems to be a biological effect with a tumor-specific immunoresponse that is clearly seen after 3 doses of therapy. The second trial evaluated the combination of nivo plus PD-L1 peptide vaccine in patients with metastatic melanoma. The results reported included 30 patients with metastatic melanoma. They were therapy naive and with no melanoma brain metastasis. The COMBI therapy seems to be feasible and safe, with a high response rate, with a response rate that is approximately 80% and higher than the subgroup that was used as a comparison and treated with PD-1 monotherapy, and the response rate of the complete responses were also very high, approximately 45%. And the authors also seemed to, or also demonstrated that there were vaccine-specific T cells in the PBMCs and also in the tumor site. What is still to be determined is if these immune responses translate into clinical benefit, and this is obviously something that we need to wait for more follow-up and for more data. Then there were 2 presentations on therapy in melanoma brain metastasis. The first one that looked into patients that progressed under BRAF/MEK and that received further ipi/nivo, and the authors looked not only into the response but also into the biology and the characterization of the metastatic lesions that progress under this target therapy. The patients actually that received this second line of ipi/nivo didn't derive a large benefit from this second systemic therapy. They looked into the median intracranial progression-free survival, and it was only 5.5 weeks for these patients that received the second line. And when looking into the lesions that actually progress and having an NGS characterization, the authors show that there was a signature that is similar to the innate PD-1 resistance signature in these metastases that progressed under target therapy. When they looked into the immunohistochemistry, they also showed that these non-responsive metastases also have an enrichment in terms of myeloid cell activation that is also known to be or to induce less good responses to immunotherapy. Another trial that also evaluated systemic therapy in melanoma brain metastasis, so in the same line of the first one that I just mentioned, is the NIBIT-M2 trial that evaluated ipi plus nivo versus ipi plus fotomostine or fotomostine in patients that were treatment naive and asymptomatic and had melanoma brain metastasis. So this longer follow-up showed that there is a clear benefit in terms of median overall survival for the patients that were treated with the combination of ipi/nivo, and also in terms of median progression-free survival. The 4-year overall survival rate was also higher for the patients that received combination immunotherapy, 41% versus 50% for the ipi plus fotomostine versus 8% for the patients that received only fotomostine. With this longer follow-up from this trial, one can say that probably the first-line therapy for patients with melanoma brain metastasis that did not receive previous therapy and that have no symptoms related to melanoma brain metastasis is the combination of ipi plus nivo. Then there were also 3 works presented on the therapy that can be provided to patients that progress during or after immune checkpoint inhibitor. The first one was the evaluation of local therapy given to patients that progressed under or after immune checkpoint inhibitor, and the colleagues looked into these two subgroups, patients that progressed under immunotherapy and the patients that progressed after stopping immunotherapy, with a similar number of patients in each group. And what they've shown is that the patients who progress during therapy are more often treated with local therapy and continuous systemic therapy. This seems to be also the approach that has more advantage in terms of overall survival. Patients that progress after stopping immunotherapy are more frequently treated with local therapy, but those who benefit more in terms of time to second progression are those that receive local therapy, but also restart immune checkpoint inhibitor. However, the results that were presented so far do not show that there is an improvement in terms of overall survival for patients that receive local therapy plus restarting checkpoint inhibitor compared to the ones that received a single modality. What we can conclude is that probably the local therapy might benefit patients with stage 4 who progress with solitary lesion. What is missing is the localization of these solitary lesions. So we don't know if these localizations might be an explanation or might be the reason for these patients to receive local therapy, and if the local therapy is feasible based on the localization of these progressive lesions. A second trial that evaluated the therapy in patients that progressed under PD-1 inhibitor was the Illuminate 204. This trial evaluated the combination of ipilimumab plus intratumoral tilsotolimod. They included data from 67 patients, and the results that were presented here on a heavily pretreated population. So the patients included could have received at least up to 2 therapies if they were BRAF wild type, or up to 3 therapies if they were BRAF mutant patients. And this might be a potential second-line therapy for patients that progress under PD-1 therapy. The results that were presented here led also to the design of a phase 3 trial that will evaluate this combination versus EP alone. What is missing, obviously, is how was this progressive disease determined? How was it confirmed? Because we say that we evaluate second-line therapies in patients that progress under PD-1 inhibitor, but the definition of this progressive is not homogeneous among the trials, so it's difficult to compare the results coming from all these trials that evaluate therapy after progression under PD-1. Then in this topic of therapy after progression under PD-1 trial that was presented as a proofed paper, but that I will mention here because it's on the same context as the 2 ones that I just mentioned, which is the LEAP-004 that evaluated lenvatinib plus pembrolizumab in patients that have progressed on the PD-1 and PD-L1 inhibitor. This was not a randomized trial. All the patients received this combination, and the overall response rate and the median overall survival for the patients that were included in this study, and particularly those that had progressed on the PD-1 or PD-L1, it's quite impressive, particularly when we compare to other studies that also evaluated second-line therapies in patients that had already progressed on the PD-1-based therapies. And the median overall survival in this case is actually almost 14 months. To finalize the oral presentations, there was a presentation evaluating the outcomes of patients with complete response under immune checkpoint inhibitor. This was a 5-year characterization of this subgroup of patients that were treated in the Checkmate 066, 67, and 69. Almost 400 patients, or more than 400 patients, were treated with EP plus Nivo, and more than 500 patients were treated with Nivo monotherapy. 96 patients had a complete response when they were treated with EP plus Nivo. And from these, almost 50% discontinued therapy to toxicity and 3 due to progressive disease. On the other side, patients that received Nivo monotherapy, 102 had a complete response, and only 20% discontinued therapy due to toxicity and 6% due to progressive disease. The 12 months landmark analysis was presented here, and both for patients with and without complete response. And in terms of overall survival, we don't see a difference in the two subgroups of treatment regarding overall survival for those that received that had a complete response. But for those that didn't have a complete response, there was a higher percentage of patients that there was a higher overall survival rate for patients that received EP plus Nivo. For the PFS, the same goes for the patients that had a complete response, but for the patients that didn't have a complete response, a higher progressive-free survival rate was seen in the patients that were treated with the EP plus Nivo. So what we see is that actually there is the patients that have a complete response have a higher over five years overall survival in both therapy subgroups. For the patients that achieve a complete response, there is a higher percentage of patients in the Nivo plus EP group that are free of treatment at 5 years compared to those that receive Nivo monotherapy. The patients that are off treatment in these two subgroups are more than 80% in the Nivo plus EP arm and 60-80% in the Nivo arm. There seems to be an association in terms of baseline characteristics of the patients and the complete response to these two immunotherapies. So normal LDH and lower tumor burden are associated with complete response in both subgroups. Lower M stage is associated with complete response in the Nivo plus EP arm. And interestingly, in the patients that have a PD-L1 expression of more than 5%, they seems to be associated with a higher percentage of patients that achieve a complete response, but only in the Nivo arm. The maximum tumor reduction is important, and probably incorporating on therapy assessments may provide information on clinical outcomes, and the benefits seem to exist regardless of therapy discontinuation. However, there was no information on how was this complete response or this cutoff of complete response at 12 months was established, and also, there was no information or no further characterization into the patients that had a complete response after these 12 months. That was a group of more than 40% in both subgroups. Then moving into the proved paper section, or in the proved papers session, there were 3 trials presented in the metastatic setting. The LEAP-004 I already mentioned. The 2 others were the COMBI-i trial and the SECOMBIT trial. The COMBI-i trial was a trial evaluating the combination of spartalizumab plus dabrafenib and trametinib in patients that were previously untreated and had a BRAF V600 mutation. And this study didn't meet his primary endpoint, although he was very similar to 2 other trials, the KEYNOTE-024 that was also a negative study or didn't meet his primary endpoint, and a study that met his primary endpoint, that is the INSPIRE-115. During the discussion, there was a very elegant explanation on why these so similar trials lead to positive or negative, meet their primary endpoint or not. And when we look into the curves, they are actually overlapping the curves from these 3 trials. So probably very small differences in terms of trial design and very small differences in terms of the population that is included might be the reason why we see some trials being positive and achieving the primary endpoint, and others being negative and not achieving the primary endpoint. It was also pointed during the discussion, and I find a very important question, whether we should be addressing if immunotherapy improves the outcomes of target therapy, or the other way around, if we should look into immunotherapy and see if target therapy can improve or not the outcomes of immunotherapy, since we know that target therapy can also induce, is also immunogenic. So probably we need to consider the question in a different way, and there are trials that will evaluate this question, as I said. For the SECOMBIT trial, this is also a very important trial that is addressing the question of how should we sequence therapy in patients, mostly in patients with BRAF mutation. And they looked into three possible sequencing. The first one that started with target therapy, a second one that started with immunotherapy, and the third one that had targeted therapy before, immunotherapy shortly after, and then target therapy after. That is mentioned as the sandwich approach for this study. Although the data is very preliminary, what we can see is that the 12 months median progression, the 12 months progression-free survival seems to be better for those that started with immunotherapy, but after 12 months, the curves cross. The median duration of response is higher for the patients that start with immunotherapy, but we see also more toxicity in this arm. And the total progression-free survival seems to be better for those that have this sandwich approach. So, and these were very preliminary reports. So we really don't know if we will continue to see this trend once we have an update of the trial. One of the aspects that was mentioned, and I find it important, is that also the time point when this trial was designed was a time point where we didn't know the final results or the updated results of the survival, the overall survival of the combination of nivo plus EP and encorafenib plus binimetinib. So it might be that the design that was proposed for this trial could be an issue when having a positive trial in the end. Then, and also based on the data that we have now, we cannot say that there is a better sequence approach in this setting. Finally, in the adjuvant setting, there was an update on the trials on the Keynote 054 and on the Checkmate 238. The trials are not exactly similar, but they were they also included patients that have received a complete lymph node dissection, which is no longer the standard of care. And in the Checkmate 238, there was an active comparator arm that was EP 10 milligrams per kilogram. The update of the Checkmate 054 showed that the distance metastasis-free survival, the hazard ratio favors the therapy with pembro, and this benefit is higher or more significant in patients with BRAF mutation with an hazard ratio of 0.54. And this hazard ratio is quite similar to what we have seen in the COMBI-i trial for the BRAF mutated patients. There is an interesting aspect, which is the fact that the benefit of pembrolizumab was not so so significant in terms of local regional recurrences, and this might be an issue that will, or might be an aspect that will even be more evident, because the majority of the patients that will receive this therapy nowadays will not have received a complete lymph node dissection. There are still pending results in terms of overall survival and the data from the crossover to pembro after relapse. The update of the Checkmate 238. So the authors also provided an update with 48 months of follow-up. The benefit of nivo continues to be evident compared to EP at this time point. The patients, the first time was presented data on patients with in-transit metastasis, and also there seems to be a benefit for nivo treatment compared to EP. And they reported for the first time data on overall survival, and what we see is that at 48 months, there seems to be no difference in terms of overall survival for the patients that receive nivo or EP, and with an overall survival of approximately 78% in both groups, 77% for the EP. And the difference, or the absence of difference in these two subgroups, is probably explained by the fact that when the patients progress, they were unblinded, and more patients in the EP arm received PD-1 therapy subsequently, and this subsequent therapy probably dilutes the benefit in terms of overall survival in the nivo group. So take-home messages. There are a lot of information coming from multicenter real-world analysis that are needed to understand how good drugs perform in real life and if the benefits is conserved across subgroups. This can be achieved by well-designed post-approval monitoring, excellent collaborative studies that have their basis on data from national registries. Adjuvant studies are now assessing toxicity of regimens since efficacy has been proven. However, still more than 50% of the patients relapse and 35% of the patients relapse with distant metastasis. So we definitely need to improve either systemic therapy by using triple combination or potentially the neoadjuvant approach, or by better selecting the patients with these biomarkers that we are still waiting. In the metastatic setting, the best sequential therapy is still yet to be defined, particularly for patients with BRAF mutation. Patients who progress under first-line therapy, particularly if they progress with a solitary metastasis, they seem to benefit from local therapy. Other therapeutic approaches with other therapeutic combinations, namely local therapy or namely intralesional therapy, might be an option, but definitely the definition of progressive disease under first-line therapy needs to be clear and needs to be homogeneous among the different trials that evaluate the second line of therapy. Achieving a complete response in the first 12 months of immunotherapy seems to be predictive of long-term survival and seems to be associated with a higher possibility of not needing further systemic therapies at 5 years. For patients that are treated with Nivo, the expression of PD-L1 of more than 5% seems to be associated with a higher response rate, with a higher number of patients that achieve a complete response, but this doesn't seem to be true for the patients that receive the combination therapy. Thank you for listening. This is the highlights from the ESMO 20 Congress, the first weekend, and the data on the melanoma trials that have been presented. Thank you.